Well, what I wanted to do today, if Paul Saladino and Dave Lee are watching, they are on one camp. Then we have the Peter Attia, and I'm going to put you in that camp too, Dr. Andrew Wingy.
Maybe.
I don't know where I am. I don't. The reason I don't know where I am is because I don't have the expertise to understand it, and I think that's 99.99% of us. I'll be honest. I love Paul. I love Peter, but they haven't explained this for the normie that we can understand to make a decision. So I think you can do that today for us.
Oh, that's a tall order, man. I don't know. I'll do my best. So yeah, I mean, so there's these two camps, right? In atherosclerosis prevention. Now, the reality is, I will tell you, in the real world of heart disease and atherosclerosis, which I still live in my day job, there's no debate in the cardiology, the major cardiology world. There's really no debate in the lipidology world. If you look at every major heart disease association, every major atherosclerosis association, the Americans, Europeans, Canadians, Australians, all of them are on the, all of them recognize that ApoB containing particles are the causal agent in atherosclerosis. So it's a bit of a false dichotomy. And I think if you were to go on Instagram and YouTube and TikTok and whatnot, you might get the impression that this is a hot area of debate and that there's a lot of controversy because, when you take a contrarian opinion like Paul Saladino does and many of these other like carnivore influencers and that, they get a lot of attention, right? It's much more popular and much cooler to be the guy that like goes against the grain, and is, trying to like stick it to the man, so to speak. There's this narrative. I was thinking about this earlier today, like in American culture, and I think it's spilled over into the rest of the world through Hollywood, this narrative about like the little guy fighting against the big corporate entity or the interest. And you see it in medicine, like the story of, the person who, the doctor said I would never walk again, but I proved them wrong. Or like the one person that like set out to prove the medical establishment wrong. And those, those are great stories. I love those stories too. But the reality is that like those stories are really like, the reason they're popular and the reason they get notoriety is because they're so rare. The story about like the guy who has a spinal cord injury and like is told he'll never walk again and then, proves people wrong is like vastly the exception. I mean, I hate to say it, but like 99.9% of people, if a neurosurgeon comes and tells you you'll never have use of your legs again, they truly will never have use of their legs again. But we don't hear about those stories. So same thing with taking a contrarian opinion with heart disease or with diabetes. If you say like, I have the real answer to that, to atherosclerosis, all of these other major research organizations, they've all got it wrong, but I know the true cause. And then of course you flavor in a little bit of conspiratorial jargon, like, they're not only are they telling you the wrong thing, but they're doing it on purpose to keep you sick and to make money, which is just not true. It's not true. So having said that, I don't have a dog in this fight. Honestly, I'm interested in slowing atherosclerosis in myself, in my patients. So my job as a doctor is to give people the best advice that I can. So I look at both of these camps, and what I find is that both sides are correct in certain areas, and both sides maybe, I won't say they're wrong, but they perhaps like don't emphasize enough a more of a holistic picture of atherosclerosis. So, if you had to pin me down, I'm definitely more on the lipid model or lipid hypothesis, where, I do agree that ApoB is causal in atherosclerosis, but I will be the first guy to tell you that this stuff is complicated, right? There are people out there with high ApoB who don't seem to develop heart disease at the rate that we would expect them to. So that alone will tell you like there's more to this story, right, than just lipids. But the lipids are the big one. I mean, lipids are like one of the, if not the most crucial aspect of this. And the take home, we'll go through all this stuff and we'll talk about it and we'll just see where the conversation goes. But at the end of the day, I mean, if you just want the quickest thing that you can do to lower your long-term risk of developing atherosclerosis, it's to crush your ApoB as low as possible. That's what the current data shows. Hundreds and hundreds and hundreds of studies performed by thousands of PhDs, lipidologists, cardiologists all around the world. That's kind of where we're at this point. Does that mean we have all the answers? Absolutely not. Absolutely not. Because like I said, there are people out there, they're not common, but there are people out there with high LDLs, high ApoBs, who on paper should have terrible cardiovascular disease, but yet they don't. So I think those people are really interesting. We need to study those people and find out what's going on. So that's kind of my approach, you know, just to give you like a 10,000 foot view on where I'm coming from with this. Again, I don't have an internal bias one way or the other. I think of addressing both metabolic health, which is kind of where the carnivore people are coming from, and addressing lipids are both important. Like, why would you not do both? Why do I have to pick a side, right? Like, don't pick a side. I want to hit this from all possible angles. If there's multiple factors that all interact to produce atherosclerosis or to enhance the development of atherosclerosis, why wouldn't I want to address all of those? That's how I look at it. Like, I'm not on anyone's team. I'm looking to reduce my own risk and reduce my patient's risk as much as possible based on the available data. And I don't know everything. I mean, for the listeners, I'm board certified family medicine, board certified emergency medicine. I take care of a lot of heart disease, mainly in the emergency room. So I see the end stage of this. And so I know what that looks like. And I think that a lot of lay people, obviously, they don't necessarily know what that looks like. And it's absolutely awful. And it's not anything I would wish on anybody. So I see that every single day. And so, you know, I want to take whatever means are at my disposal so that I don't get to that point. I don't want my patients to get to that point either. It's this is a serious subject, and there shouldn't be as much confusion as there is, but there is. There's a lot of confusion, and I get it. It's a complicated thing. This is not easy to digest, but maybe today you and I can break it down into like the most simple, basic things that all of us can do. And then we can let these other people argue about mechanisms and this and that. And again, not that I have all the answers to all of this stuff, but this is an area that I'm really interested in. I have coronary artery disease. I have it based off of a positive coronary artery calcium scan that I had when I turned 50. I'm 51 right now. So not only do I have coronary artery disease to some extent, I also have 2 young boys under the age of 2. So I want to be around. You know, I'm looking to live into my 90s. So most men in my family, I also have a genetic condition that elevates something called lipoprotein A. So I have high lipoprotein A levels, highly atherogenic. We can talk about that a little bit. That'll be one of the fundamental tests that all men and women too actually need to have. 20% of the population has this and is unaware of it. So you have to be extra aggressive with your preventative measures if you have high levels of Lp(a). So that runs rampant in my family. The men in my family typically don't make it out of their 50s, either alive or with serious cardiovascular events in their history. So my goal is to be the first to get out of my 50s with no problems and no further progression of my atherosclerosis. So again, I think about this a lot. It's not just for my patients, it's a personal thing for me. I know it is for you too. You talked about it. We've talked about it offline.
Yeah, this is my number one concern, which is why this is one of the only podcasts I do on health.
It's very selfish. Should be your number one. Well, it's not. It's, you know, it should be your number one concern because it's the number one killer of men worldwide and women for that. I mean, it makes sense. You know, let's start with the low hanging fruit, which is cardiovascular disease. You know, cancer comes second. The nice thing is a lot of the stuff you do to prevent atherosclerosis also will help you prevent cancer. Yeah, in terms of like nutrition, lifestyle, et cetera. So
sure, it's an interconnected system, right?
It's all connected. It's all connected. Yeah, dude.
Okay, I think we have a good duo here because I am that lay person that you have to convince, right? So I speak for the people today. I guess there's 2 major concerns. I know these are top 2 because I don't know about you, but I read the comment section on YouTube videos all the time. To see what the dialogue is. You do? Yeah. Man, it's valuable. You know what they say. number one concern is, yes, I recognize ApoB is an issue, but it's insignificant. So on their pie chart, the normie, this is our pie chart. We put this much is exercise, this much is sleep, this much is diet, and this tiny little piece we give to ApoB. What do you say to those people?
Well, if I had some time, I could have pulled up a really good review article that essentially just showed all of the studies that have ever been done looking at LDL, which LDL, for the listeners, is the major component of ApoB. If you get an ApoB level, almost all of that is LDL. There's other lipoproteins as well, but they tend to run together. And there is a moving from left to right as LDL levels rise, there is just a linear increase in coronary events over time. So the higher your LDL goes over time, and this is not just one study, this is dozens and dozens and dozens and dozens of studies. Basically every study that's ever been looked at was wrapped into one of these meta-analyses. So there is a direct correlation. So this is where people on the internet love to quibble over details. Most of them are not qualified to really dissect medical literature and research papers in general. And I say that sounds kind of arrogant, but it's not meant to be. But to truly read medical science and science papers in general, I mean, you really have to have had like a graduate level statistics class under your belt, because this stuff is really complicated. And the way that they manipulate the numbers to give a result can be very confusing. So if you're not familiar with some of these fancy statistical manipulations and p-values and all these other things that go into these studies, it's very easy to read an abstract, which is so the majority of people, doctors included, when they quote a study, literally all they do is they read the conclusion of the abstract, and it'll say, whatever it says, ApoB only accounts for 20% of the overall risk, which I just made that up. That's not what it is. But then they throw that around like it's like holy scripture. Whereas like if you dive into the paper and you realize like how they arrived at that data, it's a bit suspect. So you just have to be careful with these sort of pie charts. But people love to just quibble about this stuff on forums and Reddit and Facebook and all this sort of stuff. But the bottom line is that like it is irrefutable at this point. The contribution of ApoB, it's the causal agent in atherosclerosis. And I'm happy to dive into that a little bit. We can talk about the how this whole process starts, which is in childhood. It's driven by ApoB. Now, there's other factors, right? Like I'm not completely one-sided on this. Yes, inflammation is a huge contributor to this. Insulin sensitivity is a huge contributor to this. Genetics is a major contributor, which we're just scratching the surface on the genetics. In fact, I think genetics is probably one of the major factors that determines when you will get heart disease, if you'll have an event, et cetera. And I say when because I kind of feel like, this is just my own personal opinion, like the development of atherosclerosis is, in some ways, it's inevitable. I think it's part of being a human being. It's the way that our bodies have been, how we evolved over time. And I say that we got mummy studies, looking at 3, 4, 5,000-year-old mummified human remains. They had atherosclerosis, even back then, eating a natural diet, living in, Neolithic times, they still developed atherosclerosis. So I think that developing atherosclerosis is just part and parcel of being a human being. So, you want to die with atherosclerosis, not from atherosclerosis. So you want to slow that down. And I think, honestly, a big determinant of the rate of which that happens is going to end up being genetic. This is just my opinion. I don't have any papers or anything to prove that, but it's, and it explains these people that run around with high LDLs their whole life and they live into their 90s. Why is that? Well, they probably have genetic mutations that are protective against that. But the problem is we're at a stage now, like we don't have a way to test for that. So do you want to run that risk? Do you want to just assume that you're one of those lucky few that has these mutations and not address it? Or do you want to assume that you're like the other 99% of us who will develop atherosclerosis sooner than we would like if we don't address some of these factors?
Yeah, it's a good point. The second point to
I don't want to take a chance.
Sure. So I guess what you're saying there is, why risk it? Why leave any stone unturned? Like, what's the point in even debating how much is ApoB, how much is exercise?
It's pointless.
But you know what they say? Side effects. This is the next. This is the next big kind of counter. And this is actually my concern, man. I don't know what it is about me. Is it my sensitivity to medications because of my autoimmune condition? But I'll be frank with you. If I did not get some of the side effects from anabolic steroids, I'd still be taking them. I'd still be smoking marijuana every day. I love drugs, but the side effect for me, I mean, it's
intolerable.
It's nonstop. So what do we do with side effects?
The good news is that the most important things that you can do, the things that will move the needle the most for you, don't involve drugs at all. They involve diet, lifestyle. It involves regular cardiovascular exercise, low body fat, especially low visceral body fat. We talked about that before. You cannot have fatty liver disease. I mean, you have to address that. Eating a low inflammatory diet. People quibble about diet, and I don't want to go too much into it. The carnivores have their opinions, and the vegans have their opinions. And if you want to look at the research that's out there, it's probably somewhere in the middle, meaning like a Mediterranean style diet seems to have the most. If you want to look at data, as good as it is, it's probably a Mediterranean style diet, which for me is great news because I like to eat that kind of stuff anyway. It might not be everybody's cup of tea, but so the major things for you and for all of us don't involve medications. There's no side effects to eating better. There are no deleterious side effects other than it can be expensive. There's no negative side effects to regular exercise, assuming you don't get injured. There's no negative side effects to not smoking. There's no negative side effects to, like controlling your blood pressure through like limiting sodium if you're salt sensitive, to taking all the right micronutrients, magnesium, all that stuff. That's like the biggest piece of the pie, in my opinion. And then the medications are for those people who have those genetic tendencies. If you do everything perfectly, but your ApoB is 130, well, then that's probably your genes, right? I mean, the genes play a big part of that. And then at that point, you have to have a discussion about medication. The nice thing now, I mean, these days, it used to be we had no options, or very few options. We had statins, and that was it, fibrates, and we had niacin, all of which in some people have pretty serious side effects. There are many people that don't tolerate those drugs. The number of available medical options now are increasing every year. We're getting new agents that work in different ways. So if you're one of those people that is doing everything perfectly, yet you still have elevated risk based on your ApoB levels, then we have a buffet in front of you of different medical options. And if you have side effects with one, that doesn't preclude you from trying other medications, working with your cardiologist, lipidologist, your family physician, whoever, to find something that will work for you. But
what do you say to my cardiologist, in Europe, that will not give me a PCSK9 or even a statin because my ApoB is 1 or it's about 100, anywhere from 90 to 100? What do you say to him?
Yeah. Well, I know where he's coming from. So first of all, you're in Europe with a socialized medical system over there. So they practice, there's a big difference between practicing population medicine, which does take into account cost, versus practicing individualized medicine. And I would encourage people, if they can do it, if they can financially afford it, you want to practice individual medicine. He's not giving you a statin probably because, and there's a 10-year ASCVD risk calculator out there. Anybody can Google it and look it up. You put in your age, you put in your blood pressure, you put in your lipid numbers, and it spits out a number. It says, this is your risk of having a coronary event in the next 10 years. And it'll give you, low, medium, high risk. Oh, you're under 7.5%. It'll tell you, okay, you don't need to treat that with a statin. That's population-based medicine. There's a big problem with that, and that is that's a 10-year risk model. So you and I both want to live a lot more than 10 years. I want a calculator that will give me a 40-year risk. What's my 40-year risk? I don't ever want to have an MI. I don't ever want to have a stroke, but there's no calculator for that. So, that's what I would tell your cardiologist is like, okay, granted, his risk of having an event in the next 10 years is quite low, but his risk of having an event in the next 50 years is very high. It's very high. It's probably well over 50, 60, 70%. You get into your 80s and then you're taking it day by day. You will have, statistically speaking, unless you're one of the lucky genetic few, if you're running around with an ApoB of, 100, 130, you're very likely to have, based on all the studies I mentioned earlier, very likely to have diffuse atherosclerosis by the time you're in your 80s. Now, I know you feel the same way. I don't want to have any atherosclerosis in my 80s, but I have a little bit. So I don't want to have any more than I have right now. And the only way to do that is to address both sides of what we just talked about: the diet, lifestyle, the inflammatory issues, all of the secondary things, and crushing ApoB. I mean, that's where we're at with the current data. So you try to live as cleanly as you can. You try to do all the right things in your life, and then residual risk is managed with medication, because residual risk now is a genetic thing and you don't have any control over that. So your cardiologist, I would say, is being short-sighted, but he's also doing what he's been told from his superiors, right? If he starts prescribing statins to guys like you, if he puts you on on an expensive medicine like a PCSK9, and he keeps doing that to guys like yourself, he's going to get an email. He's going to get an email from somebody at Department of Public Health there in Europe, and he's going to get in trouble, and he's going to be forced to not do that anymore. That's socialized medicine. Doctors don't get to practice independently. They have to follow these established guidelines, and they're not allowed to deviate. It's the same in the States. If you're under a big managed care system, you have to stick to the formulary and you have to follow the algorithms. And if you deviate, you better have a good reason for doing it. And if you deviate too much, even if you do have a good reason, you're going to get flagged and you could potentially lose your job. So that's just the way it is.
What do you say to some of these respected cardiologists that think Dr. Peter Attia's new parameters for ApoB are too low, even dangerously low to them? What do you say to them?
Well, I'm not familiar with quite how low he's talking about. I'm assuming he's in line with
less than 60, preferably 30,
Okay.
or even 0.
So where he's getting those are from the new European Atherosclerosis Society guidelines for people that are at the highest risk. So, these ApoB under 60, some say under 55, for high-risk individuals, that's you won't get too much argument from most cardiologists on that. So those are people that have had an event, or they have a stent, or they're high risk in some other way, or if they have high Lp(a), like I do, that automatically puts you in a high-risk category. So there shouldn't be too much pushback from the general cardiology and lipidology community for that. Now, there also shouldn't be too much pushback, even for someone like you, because in terms of causing harm. We have good data now going on almost 10 years that there doesn't appear to be any negative effects from bringing your ApoB down to like 10, 20, even lower than that. There does not appear to be any negative effects from that based on what we know currently. If a cardiologist pushes back, he's going to be one of these, there are just a small number of cardiologists out there, but they have loud voices on the internet and, like YouTube and whatnot, because they're contrarian, because they take a view that is contrary to the major cardiology and lipidology societies. So they do get a little bit of attention. And what I would say to them is, okay, prove it. Okay, show me the data that says if I put Dan on a PCSK9 and a low dose of a statin and I make your ApoB 10, show me that I'm causing harm. And the way it stands right now, they're going to have a very difficult time doing that.
I looked into PCSK9 papers, and I'll be honest, I know Peter Attia plays PCSK9 side effects down because word for word, this is what he says: no side effects. Like, he literally says nothing. Like, those are the words used, and
he should never say those. So the word, I say this a lot. I've been in medicine now. This is 25 years I've been in practice. And the words never and always, I've really tried to like strike from my vocabulary, because I've just learned over the years, as soon as I say that, there's going to be the exception, right? There's going to be the person that comes along and proves me wrong, either a patient or another physician, something like that. So yeah, you can't say that. And if you look at the package insert, there's a whole list of potential side effects on there. Now, what I will say is that all of those they tend to be relatively minor. Like the number one is injection site pain. Well, give me an injectable drug that doesn't have a side effect of injection site pain, right? That's like the nature of the delivery system. It's probably going to hurt when you poke a needle into your skin, right? But there are others, GI upset, flushing, all this sort of stuff that were reported. And so, yeah, I would never say that. I would never say that. What I would say is that side effects that are adverse enough to make people want to stop taking it are vanishingly rare. And I can't give you a number because I don't know. I've never had anybody stop a PCSK9 that I prescribed. I can say that too about ezetimibe, Zetia, that blocks intestinal cholesterol reabsorption. People will tell you, yeah, I've had a few soft stools, maybe some gurgles in my stomach every now and then, but I've never had anybody in 20 plus years say this is intolerable and stop it. Okay. Now, I can't say that about statins. I've had a handful of individuals over the years who had intolerable muscle pain, and we had to take them off. And that's a thing. So it just depends on the drug. But PCSK9s, I would never say that. They're fantastic drugs. I'm actually trying to get on one currently out here in the UAE. I've got an appointment next week to talk about it. So we'll see how progressive they are here. I have a feeling they won't be, but I'm going to plead my case. So I am pro PCSK9 in the right individuals. Do I think everybody needs them? No, but they're very useful drugs.
Let's use me as a case study then, because I would say I'm one of the most sensitive individuals to medications because of a digestive/autoimmune disorder. By the way, diagnosed by thyroid antibodies. So when I get a digestive issue, symptoms, if I check my labs, they tend to elevate in the thousands, not hundreds. So it's very prominent. I can't even take fish oil, man. It doesn't matter what brand you give me,
Really?
Carlton's.
Okay.
I'm going to get these burps, and then these burps will turn into some sort of fermenting, and then I'm going to get digestive issues and gastroparesis, whatever. So if it's metformin, fish oil, statins, anything orally, it just doesn't work for me. Okay. So PCSK9s, I looked at them, and I'm looking at them as my last resort. What do you say to people that say, I don't want any side effects because I feel good? And to be fair with you, I'm 35 this year. I can, walk through walls still. I'm on TRT. I don't feel bad. And the moment I take a medication, I tried semaglutide, 10th of the dose.
Oh, yeah.
Bro, never again.
Not good. Not good, huh?
I'll be honest with you. I'd rather be heavy and die.
Yeah, understood.
So what do you say to those people?
So this is, that's a tough situation, right? Like you would be a challenging patient. So much of, this is where you have to sit down and really kind of decide, like, what is your level of personal individual risk, and make a decision. Now, you're young, you're otherwise healthy. I know you have an autoimmune condition. The only traditional risk factor that you have for coronary artery disease is your sex, just being male. Okay. Now, you mentioned you had used anabolic steroids for a period of time. What that did to your lipids, did you lay down some extra plaque during those months and weeks or years that you did it? I don't know.
Yeah.
You might have. It's all about duration, right? Let's assume maybe you did, if you have no risk factors at all, if you're perfectly healthy, they currently are saying like an LDL of like 100 is reasonable, which actually a lot of people can reach that with just lifestyle interventions. But as you start stacking on risk factors, you're overweight, you have a history of smoking, you have a family history of heart disease, etc., then those targets start going down. And those are based off large population studies. So it would go down. If you had 1 or 2 risk factors, now it would be 70. Okay. And if you have multiple risk factors or you've had an event, it would go, all the way down to the, in the highest risk category. We want to get you down into the 50s or less for your LDL potentially. So some of this it's what's your level of, it's all about quality of life as well, right? Like there's not a lot of point in me, I could load you up on statins and ezetimibe and a PCSK9 and get your LDL or your ApoB down to 5 and feel really good about myself that I lowered your chance of having a heart attack. I almost eliminated your chance of having a heart attack. But if you're miserable, I actually haven't helped you at all. If I've destroyed your quality of life with these medications, then and that's obviously not the right approach. So it's tough. Like I don't have I don't have an easy answer for you other than, there are new medications coming out all the time and that, it's not unreasonable to do a trial of therapy with these medications. In addition to that, also making sure that you're hormonally optimized. We don't talk about that too much in the cardiovascular world, but I think we should. You mentioned you're on TRT. That's fantastic. You don't want to take an AI.
Never.
You don't want to be crushing estradiol. You don't even want to be lowering estradiol if you can help it. Estradiol is one of the most beneficial parts of TRT. You want to make sure that your thyroid is optimized. I learned the hard way as a young intern with a patient who I could not get their LDL down or their triglycerides for that matter. And I was starting to push like heavier and heavier doses of medications and was just getting like minimal improvements until I had one of my senior, attending sort of smack me on the head and say, "Hey, dummy, have you checked your thyroid?" Yeah, sure enough, they were at subclinical hypothyroidism. And it wasn't until I corrected that their lipids finally just fell into line. And then they still needed medicine, but it was a tiny amount. So that's really important. Making sure you want to be checked every box in terms of health, and that includes the endocrine box. There is a use case for this. Always ruffles some feathers and raises some eyebrows, but there's a use case for men on TRT to take estradiol, all right, as a cardiovascular preventative agent. I do it myself. And again, it's like my lipoprotein A levels are high. Estradiol is one of the very few things that actually lowers estradiol. I've been able to cut mine about 35 to 40% by taking 1 milligram of estradiol a day. So it's pretty impressive. Yeah. Now, whether that's going to be enough to offset the risk, it's still above where it should be. It's still well above the reference range, but it is less. And that's with a naturally occurring hormone. I have had no side effects from that. I feel completely fine. I don't have EED. I don't get emotional. I don't have nipple sensitivity I don't have anything. But my lipid numbers have improved on it. So for someone like you that's, intolerant of so many different medications, I would say we just need to take a really broad view and look at all the ways to improve your lipids, not just lifestyle. Maybe there's some supplements out there that you could potentially use. Most of them are not terribly effective, but we might stumble on something that you can tolerate. And the hormones, maybe we can take a hormonal approach to lower your risk. You just have to take the MD. I'm an MD. I know, I'm not a pill pusher by nature, but we do learn a lot of pharmacology. And so it's natural for us, when you go see an MD, they're going to be thinking pharmacology generally first, but really we should, have the blinders off and look at all available options, not just medications. We can talk about hormones, supplements, lifestyle stuff, etc. So that's how, I guess, in a long-winded way, answering your question, what would I do with someone like you is I would take a 10,000 foot approach and see what else we could do to get your risk down by lowering your numbers. So
it's very interesting. We continue then with this case study. So we know I can't get this PCSK9 here in Europe, at least not easily. And that is affecting my quality of life. Just how annoying it is, right?
it is annoying.
So it's annoying. It's like I can't be focusing all my days trying to shop around to get a PCSK9.
Right.
It's
right.
It's not going to happen.
Yeah. I know. I went through the same thing in the States. And the VA wouldn't prescribe it for me either, even though I had established coronary artery disease and a high Lp(a), which should have qualified me for it. They said, no, I had to have a heart attack first, and then they would give it to me. Yeah, those are their words. I'm not making that up. Those are their words. have a heart attack first, and then we'll prescribe it.
Man, I had to fly to Colombia to get HCG and FSH because they wanted me to come off TRT to get my fertility back here. You know what I mean?
Of course they did. Of course they did, right?
I just couldn't be bothered. I just took the flight and just did it.
Well, this is a good example of, as things progress in the world, there will be more and more potential restrictions, and the cost of healthcare will go up. It's so important that those of us who can, first of all, become as knowledgeable as you can about whatever condition you have. Just try to find good, and that's part of what this is all about, giving out just good information. Try to become as knowledgeable as you can. The fact is, like many times, you're just going to have to take your own healthcare into your own hands. And that might sound strange coming from a medical doctor, but that's where we're headed. That's where we're headed. You're going to run into doctors whose hands are tied, who can't prescribe you a PCSK9, for example, even though you may need it. You're just going to have to get creative. That's where it helps to have resources to do that. Not everybody can do that, but certainly the knowledge is out there for free. There's no reason you can't educate yourself. I don't mean you specifically because you're already well educated, but people out there that have, it's shocking to me, people that have, serious medical problems and literally know nothing about the condition. You really need to know as much as you can to make sure you're getting good care.
Yeah, especially as a man. If you're a man, you don't understand basics of health, finance. I don't know, what are you?
What are you doing?
What are you doing?
Well, what you are is a victim, essentially, or you're open to becoming a victim or victimized by the system, and perhaps being given poor advice, perhaps well-intentioned advice, but maybe poor advice that's not the best advice for you as an individual. You'll get population level advice, like I mentioned before. You don't need a PCSK9, you don't need a statin. But is that really great advice for you as an individual? Maybe not. Maybe not. So you have to educate yourself.
How much of this is genetic, though? So let's talk about you, for example. I doubt anyone when you were young was telling you what to study. You just intrinsically knew, I got to be strong, I got to be fit, I got to be educated.
Yeah. Yeah, I gravitate. I don't know. I mean, I came out of the womb wanting to work out. So I have no explanation. When I touched my first set of barbells, I was like, there was something magical that happened. And I was like, this feels, I don't know what this is, but I just need to do this. And that was in my early teens. And it's stuck with me. So yeah, I don't know. It's just how I'm wired. I was always actually interested in medicine. Like as a little kid, I would always watch the science shows, and my parents were really good. They would encourage that. They'd buy me medical books and things like that. So I had a natural interest, and I don't know why that is. I mean, who knows? I'm sure my kids will develop interests of their own that I can't explain either. But I was always interested in physical fitness. Not so much bodybuilding. I never was really pulled to that, but I was interested in powerlifting. There's just something about being strong that appealed to me. Just being physically strong, being the strongest guy in the gym at one point in my life actually mattered to me. I don't care now, of course, but that was definitely a goal in my late teens, early 20s. So I think it's just the way that I'm wired. But my interest in cardiovascular health, I didn't have that when I was in my early medical career. I was a young physician. I was interested in it just, because I was dealing with it every day. But it was only later as I started seeing just more and more people with the end stages of it, seeing my father go through all of his angioplasties and cabbages, and then his very smart cardiologist finding out he had high lipoprotein A as the cause. And then I went out and got tested because it's an autosomal dominant genetic trait, meaning 50-50 chance I passed it on to my kids. When I found out that I had it, then I sort of started connecting all the dots. I really need to do something about this because I see what my dad's going through. I don't want to go through that. And then I started paying more attention to, of course, what my patients are going through. And then when I started doing full-time ER work, where I'm literally I'm seeing heart attacks every single day, multiple times a day, many of whom don't survive, having to go tell families that their 45-year-old dad is not coming home, sometimes more than once a day I had to do that. That started really hitting home for me. And then, of course, as we've talked about, once you have kids, then it really starts to hit home. Like, I need to really take care of myself because I'm an older dad. And even if I wasn't, I want to be around. And I see it every day. Guys in their 40s dropping dead from heart attack. I posted this on my Instagram, but I was working last week. And in one shift, I had 3 STEMIs, so ST elevation, myocardial infarctions, the big ones, come in almost like back to back to back. So 3 in one shift. And the first one was 30 years old. The next one was 35 years old, and the last one of the day was 50. So I'm 51. So it really, as I get older, it's really hitting home. All these guys coming in, either cardiac arrest or on the verge of arresting, that are sometimes like 10 or 15 years younger than me. It's really eye-opening. And it's motivating to.
What do they look like? These 30-something-year-olds.
So I probably should do a video on this, but so these were all South Asian males. So I don't remember the exact countries, Bangladesh, Sri Lanka, India. They were not obese by BMI. So they were, relatively lean, but they were I would sort of call them the skinny fat phenotype. So, low muscle
Sarcopenic obesity.
They were borderline sarcopenic. So skinny legs, skinny arms, but kind of round in the middle. And I'm willing to bet not all of them had lipid panels in their system or in their file. 2 of them did. They all had LDLs of like 150 to 180. So they had high cholesterol, untreated, of course. But I'm willing to bet that if we had tested those guys more extensively prior to this, they probably had like prediabetes, probably had fatty liver disease. There is a genetic thing, getting back to that, in the South Asian population. There's something about that population. They're very high risk for type 2 diabetes and, of course, cardiac disease. They go hand in hand. So
I can tell you why. I can tell you why those people are. So I have lived in Indonesia on and off for 10 years. When I say this with confidence. 99% of them, listen in if you want, guys, drinkers, not 99% of them. Doesn't matter whether they're Muslim or not, trust me. All right? Right. Drinking, smoking, sleep deprivation, their diet, all right? Nah,
it's horrendous. Horrendous, I'm sure.
It's hard for you to comprehend, but obviously they don't have access, a lot of these people, right? And then also they don't really understand what exercise is. Maybe some out in the rice fields do a little bit, but that's them. So how could we really say it's genetic when the majority of the population have these little pot bellies with little skinny arms, like all of them?
Yeah, and many of them are vegans, is my understanding too. There's a lot of
Hindu, yes, Hindu one.
The Hindus are vegan. So yeah, I think I had a conversation actually with one of my physician coworkers who is South Asian, and that's what he was saying. He's like, a lot of this is dietary. Many of them are vegans, and they have very little protein in their diets, lots of carbohydrates. But there are people that eat that way and don't get heart disease as well. I think there's, like always, it's multifactorial. I didn't mention, the 3 guys I saw, they all were either active smokers or the 50-year-old, I think, was a former smoker. But the 2 young guys, everybody smokes here in UAE in the working class. So, it's more than just genetics, obviously. But, it's a good reminder, like, heart disease starts in childhood. It really does start in childhood. We know this from autopsy studies. So, the question becomes, like, when is the right time to intervene with medications? And I'm not going to pretend that I know the answer to that, but it does seem like you want to intervene at a point before the disease has established itself significantly in the artery. So this 30-year-old guy, he had a 98% LAD lesion, the big widowmaker, but he also had a 70% blockage in the right coronary. He had 2-vessel disease. So, it usually takes about 10 years or plus to build a decent plaque, if not longer. So this guy, maybe we should have intervened on him in his late teens. I don't know, to prevent that, but I know it is preventable. But the question is, like, when do you intervene on people? Many times people don't get their lipids under control until they've already had an event, at which point it's just damage control at that point. So
what about these smokers? You said about smokers, right? See, Bangladesh,
Yeah,
Indonesia, I don't know if you've been to Jakarta. The air quality there, it is
terrible.
comparable to someone smoking all day.
Yeah. 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 So I've heard that too. And also places like in Mexico City before they did some, I know they've done some cleanup efforts, but I lived in Mexico City for 4 years as a kid, and I remember the smog, through the city. And so, yeah, of course, you're breathing these pollutants. So that gets back to like this other part of atherosclerosis that's not the lipid part of it, right? It's damage to the endothelium, in chronic inflammation, toxins, microplastics we're finding out now, all are likely contributing to this. The lipids, and we spend most of our time talking about lipids. That's what most doctors talk about is lipids. But we do want to give the carnivores and the group that is downplays lipids, we want to give them their due. I mean, those things matter. They matter a lot. The health of your blood vessels, the health of that endothelium, which is it's only one cell thick, but it's so important. That's beyond that. That's where these apolipoprotein B particles, that's where they get contained and trapped, and that's where this whole process of atherosclerosis starts. And if you have high levels of inflammation, if you have cigarette smoke and these pollutants and microplastics, we know that layer is damaged. And so the amount of ApoB that gets in there and starts stirring up problems is probably going to be increased, right? But I will say, the thing that the carnivores have wrong, in my opinion, and I guess time will tell if I'm correct on this and if cardiologists are correct on this, is that they think that because their metabolic health is so good, their insulin is low, their inflammation is low, they're lean, they exercise, they think that their endothelium is bulletproof and that it doesn't matter that they've got an ApoB of 200, that none of that ApoB can pass their bulletproof endothelium because it's so healthy. Or if it does, it doesn't get stuck there. It goes in and then it comes out. And I will just say that all of the available data that we have now would suggest that that's not true. So, time will tell. I know there's people in the carnivore community that are doing studies with CT angiograms and whatnot. But this is hard to study, right? Because like I said earlier, atherosclerosis takes decades to establish itself. So if you go on a carnivore diet for 3 or 4 years and you do angiograms on either end of that, maybe that's quite possible there's not enough time to build up a detectable amount of plaque, detectable via CT angiogram, which is not a perfect test. It's pretty good, but it's not perfect. So, we have to address everything, right? Don't smoke, get your inflammation down, but the lipids are equally important part of that, if not more. They're probably more important, honestly.
Do you see guys like me in the ER? So let's explain guys like me, maybe.
Not very much. No. I mean, what I see both when I was in the States and here in UAE is, so in UAE, I will say it's skewed to a younger population. So, but I see, people with 3-vessel heart disease. There's a lot of kidney failure here, way more kidney failure than back in the States. And it's from untreated hypertension most of the time. So that's a huge part of this that we haven't really talked about, but blood pressure control is like one of the cornerstones of maintaining vascular health. So I see it in a younger population here, and it's for all maybe the reasons that we talked about. Maybe it's genetics, certainly dietary. There's higher rates of cigarette smoking, et cetera. I don't see young, fit guys who are on TRT, for example, in the emergency room very often. Or if I do, it's for like a non-cardiac related thing, it's a bicep tear or something like that. But that doesn't get you off the hook, right? Just that doesn't mean that you won't eventually be, and I don't mean you specifically, but I just mean you, like I'm using it plurally, that someone in those, who fits that description is not going to develop heart disease. It just may be, if you're doing everything right, it may be later on. Maybe it'll be in your 60s. But I don't see guys like yourself very often, like in your 30s, coming in with heart attacks that look like you, that do the things that you do. There's usually a lot more to the story. But that doesn't mean you don't have atherosclerosis. In fact, you do. I mean, statistically speaking, you do. We all do, right? We all do. So It's just
How about older guys?
I see older
Did
guys.
your
Yeah.
sorry, guys that look like you? So in your family, these men, rest their souls, obviously.
Yeah.
Did any of them look like you?
No, the lifting weights was not a thing, obviously, in my dad's or my grandfather's generation, but they were all like very fit farmers. My grandfather played semi-professional baseball, so there's pictures of him, during the Great Depression, looking like about as yoked as you could get without being a bodybuilder. So there's natural genetics there, and all his brothers were similar. They're all like tall, broad-shouldered Scandinavian guys, working the fields back in the 1920s and 30s, and many of them just dropped dead for unexplained reasons because nobody knew in the 30s, 40s, and 50s. Well, people just your heart just gave out. Nobody knows. They didn't do autopsies, but in hindsight, it's overwhelmingly likely that they all had high lipoprotein A and they all had sudden cardiac death, myocardial infarction, probably from atherosclerosis. I mean, that's by far the most likely thing because they did a lot of them, not all of them, but a lot of them smoked because almost all men smoked in the 30s and 40s. It was just kind of a common thing. But again, they all likely had lipoprotein A. So you can be fit as a fiddle, as they say. You can be. I'm thinking of the guy from The Biggest Loser. Was it Bob? The trainer, I forget his last name, Bob Harper. You know what I'm talking about, right?
Yep.
Pretty fit guy. So he had a cardiac arrest in the gym at age 48. And the story, as far as from what I hear, is that there was a medical student there who knew how to use an AED, who shocked him, and he went, straight to the cath lab and had one or more high-grade blockages. And you're like, how is this possible? This guy's like completely fit, healthy. He had LP-A, high lipoprotein A. So he's actually now like a spokesman, I think, for the Lipoprotein A Society or something like that. So he tries to get the word out about this condition. So that's in my family, even though, I'm physically fit. My dad he was physically fit in his younger years. All of my, male relatives, pretty good genetics from an athletic standpoint. Nobody would look at them and be like, yeah, of course you had a heart attack. They had high lipoprotein A. So when you have that, that's why I said that automatically puts you in a high-risk group, and it's lifestyle resistant. There's nothing I can do from a lifestyle standpoint to lower my lipoprotein A. That doesn't mean I still shouldn't do those things, but the only answer is medication or hormonal manipulation in my case.
Can we talk about that? I got two questions.
Yeah, absolutely. Yeah.
It's great. First question, because it's nuts. We need this one. When you said lifestyle resistant, I'm stealing that from now on.
Okay.
You spoke about high, little PA. I know people are listening going, how high is high?
Yeah. So good question. So, the standard reference ranges, you'll see it in milligrams per deciliter, or I think it's nanomoles per liter. So the numbers will vary. Milligrams per deciliter, like anywhere under 30 is considered to be normal. And above 30, that's where the risk starts to climb as you go above 30 milligrams per deciliter. And I'm trying to remember, I think it's 70 for nanomoles, either 70 or 75. So it depends on what assay you use. But they pick those numbers because that's where, when you look at all-cause mortality and cardiovascular events, that's when you start getting the inflection upwards, is above those thresholds. And the higher the LP-A, the higher the risk, regardless of other things. It's an independent risk factor in and of itself. So, you do want to obviously try to lower that if you can. The problem is that it's lifestyle resistant, it's hereditary. And there are a handful of drugs, maybe not a handful, there's 2 or 3 in the pipeline, phase 2 trials that appear to be very effective at targeting LP-A and lowering it significantly. But it's going to be a few years until those are available. So as it stands right now, there's not a ton of options for lowering LP-A. Niacin, extended release niacin, does lower it, but we've done big studies with niacin, and essentially it didn't really reduce cardiovascular events, and it was liver toxic for many people. It caused some unfavorable changes in HDL, which is a real bummer because I used to take, so for most of my 30s, I knew I had high LP little a, and I was taking extended release niacin because I didn't want to take a statin. Statins don't really lower LP little a. They might actually raise it a tiny bit. So I was like, I'll just take niacin. And I prescribed it to my patients too, back 15, 20 years ago. But nobody prescribes niacin anymore because we've had some big studies showing that it's probably not effective for what we want it to do. So the LP little a, the best way to address LP little a as it stands right now is to lower your ApoB as much as possible to offset the risk. LP little a contains ApoB as well. It's one of the ApoB containing particles. But if you have high LP little a, I mean, you want to get your LDL like down to 25 if you can. And that's where, obviously, clearly medications are going to be for the vast majority of people, you're not going to get there without probably multiple medications. But this is for the 20% of the population that has high LP little a. The other 80%, you don't have to do that necessarily. But it's tough. Well, LP little a is tough to treat, but there's a reason why women get less atherosclerosis than men, and then there's a reason why they tend to catch up in the postmenopausal range, and it's estradiol. Estradiol is largely protective against the development of atherosclerosis, and it acts at almost every step of the way in the development of plaque, but it also is one of the few things that lowers lipoprotein A. So women tend to not have high LP little a levels necessarily, or not as high as men until, if they have the gene, until they hit menopause, and then the protective effect of estradiol goes away, and then you'll see their LP little a will rise, significantly. So my sister, I don't know if she's been checked. I hope she has. I'm going to go remind her to go get her LP little a checked, because she has a 50% chance of having the condition. But she's almost my age, getting it to the point where she's going to lose the protective effects of estradiol. So she has to really be on top of that because her LP little a levels could rise. So we know that estradiol lowers it. It actually has been studied in men and in a few small studies. But, again, I'm interested in living for a very, very long time. So for me, until there's a better option, I take a milligram of oral estradiol per day. And it's so far, it has made the number go down. Does that translate into a lower risk? I would like to think so. I don't have any proof of that, but for now, that's what I can do. So that's what I'm doing.
Very interesting. I just got a couple follow-ups. I was looking for my little PA. I know I'm in the normal range, but it's at the high end of normal, but I'll find that later for the audience.
Okay. Yeah.
When you speak about estrogen, when you say 1 milligram per day, I know a lot of people are thinking the same as me. They might not want to take estrogen, but they could increase their testosterone dose, or they have higher naturally estrogen than normal. How much does that equate, 1 milligram of estrogen, when it comes to taking testosterone? How much are we talking here in increases of your
Well, I can speak from my experience. So without going down the rabbit hole of why testing serum estradiol levels is not a particularly useful thing, I have still done it. And it varies widely based on my body fat percentage. So I have checked my serum estradiol level just out of curiosity when I was really lean, like 5% body fat, and it was about 14. And that's with a serum testosterone level about 1,200. So,
wow.
I'm not a big aromatizer, and, body fat percentage, especially visceral body fat, has a high amount of aromatase in it. So the more visceral body fat you have, the more estradiol you will produce for a given amount of testosterone. So I've been as low as 14. Right now, I don't know what my body fat is. It's probably 14, 15%. I had it checked a few months ago, or not a few months, about a year and a half ago, and it was like 28, 29. I've been as high as like the mid 30s with a similar testosterone level, like serum, like roughly 1,200 total. My free tends to run like 24, 25. So, and I feel no difference, obviously, between the two numbers. So now that I'm taking a milligram of oral estradiol, I've only checked it once, and it was just as an experiment. my level was it 51 or 52, something like that. It was in the low 50s. So almost doubled, my previous when I'm in my, sort of normal state, when I'm not super lean. And, I think a lot of guys in the TRT world would look at that and be like an estradiol level that high. It's above the quote reference range, which is useless for men on TRT. But they would say, oh, that's too high. Like you need an AI, But I feel perfectly fine with that level. In fact, I may go to 2 milligrams. I know a number of physicians that take up to 4 milligrams a day of oral estradiol who have, because of serious lipid issues and because of statin intolerance. So I don't know that I need to do that, but I'm not afraid of upping my estradiol level because I have a solid testosterone level, behind that. And so I'm not worried about getting gynecomastia, et cetera. But this goes back to like yet another reason why, men should not take aromatase inhibitors, especially if you're in the 20% that has high Lp(a). You're literally lowering like the one thing that's helping keep your Lp(a) in check, so to speak, which is estradiol. You do not want to. You don't want to. Why would you lower your estradiol when you have high Lp(a)? I mean, you're asking for problems. There's other solutions to these so-called estradiol symptoms. So,
would you increase your testosterone ever?
Probably not, although I'm not afraid to do that. If I go to 2 milligrams and I start having side effects, then that tells me I probably should back off on the estradiol. Although, I could do an experiment, obviously, and increase my T levels to see if it's offset, and that may be worthwhile doing. But I probably would just back off. If I go to 2 and I don't feel well, if I get ED for some reason, which I doubt will happen, I would just back it down. That's just me. But again, I think estradiol is not the boogeyman that many people in the bodybuilding and like TRT community think it is. And quite honestly, like if you want to make it into your 80s and 90s with, for lack of a better term, with clean pipes, one of the worst things you can do is lower your estradiol. You want a nice, healthy estradiol level throughout your lifetime in order to help keep your arteries young, keep them pliable, and to minimize the amount of plaque that you develop. And that's true whether you have Lp(a) or not.
Certainly. Let's talk about the elephant in the room here, especially for both of us. We touched on it last time, but it's something that, if someone asked me, what do you think the number one thing you could do, Daniel, to reduce your CVD risk based on all the things I've checked over time, all the metrics?
Yeah.
It's not my body fat. In fact, I've been a lot leaner and unhealthier. So I haven't actually found a benefit from 10 to 15%. I'd even say a benefit being 15. Now, that's a topic for another day. I don't want to get people disagreeing with me because I know they could. But my weight, the reason I don't increase my testosterone dose, even though I objectively think that my libido is a little better, I recovered better for sure, it's my weight. Do you not worry about just weight in general, even if it's muscle?
Sure. Yeah, this is it. We did talk about this last time. Obviously in nature, we don't see a correlation between weight, meaning just mass of an animal, and its lifespan. Well, the correlation we see is that the bigger the animal, the longer it lives, right? The shortest living mammals are like little mice and rodents. Then we have like blue whales and tortoises and big, Galapagos tortoises and whatnot that live forever. And sharks, Greenland sharks, they live for several hundred years apparently. So there isn't in nature like a direct correlation, but I think what you're getting at is, are you, being bigger than your genetic set point? Is that probably more like what you're talking about, like without excessive androgens? There probably is an inflection point there at some point. I just don't know where it is. And, the things that can happen when you get a ton of muscle mass, obviously, sleep apnea is an issue. I would guess that probably 100% of the guys on the Olympia stage have some degree of sleep apnea, at least in the off season. Certainly all like the world's strongest man guys with just all of that mass, especially when they're supine, they're going to need some support to keep their airway open. So, there starts to become some problems there for those guys. But again, those guys are well above their genetic threshold, like far above what they would ever have been naturally. If you reach your genetic set point, your max, could there be problems? Probably not. That's my guess. I don't know that anybody's ever looked at this. I will tell you, like, metabolically, muscle tissue, there's no point in which increasing muscle mass doesn't improve metabolic health that I'm aware of. The more muscle tissue you have, the more of a glucose sink you have, the more insulin sensitive you have, the more of these beneficial myokines that are secreted. Muscle, just like fat, is a bit of an endocrine organ, so it secretes these substances which tend to be beneficial and healthy for blood vessels and heart and things like that. So, it's not the muscle mass per se, I think, that could be harming these guys. It's perhaps, like you said, the weight, and it's maybe more of a mechanical issue with the airway, that sort of thing. And then also, blood volume, high blood volume. That's one of the components of blood pressure, and then is the heart having to work harder to push that volume? Could you be developing left ventricular hypertrophy? Certainly with the androgens on board, again, I bet if we did echoes on all of the Olympia guys, they would probably all have ventricular hypertrophy. I feel pretty confident in saying that. So bottom line is, I don't know. I think there probably is an issue with mass, but it's probably way at the extreme ends is kind of my gut feeling on that. That if you put on, let's say, an additional 10 pounds of muscle tissue, could I give any evidence that would shorten your life in any way? I would say no, I can't. Could it? Maybe, but I would say probably not. Now, if you put on 70 pounds of muscle mass and you took a boatload of trend to get you there, I'd say, yeah, probably there's an issue there. But maybe it's more the trend that the muscle tissue. I don't know.
I was more
In
thinking
general,
150 milligrams. Sorry, go on.
I would just say, though, in general, though, having more muscle tissue, I talk about this all the time, like more muscle tissue after the age of 50 is a survival benefit for you. If you get a critical illness, if you're critically injured in a car accident, you want to have a substantial amount of excess muscle tissue that you can spare, that you can afford to lose. If you're sarcopenic and you get in a major motor vehicle accident and you're bedridden for 6 weeks, good luck going home after that. You're going to have to go to a rehab center to learn how to walk again, not because of neurological problems probably, but just because of muscle weakness. But if you're 230 pounds and you lose 70 pounds of muscle tissue from being in a bed for that long, at least you've got that excess tissue. I think you're going to do better. You're going to get back to at least living independently faster than the sarcopenic person will. So muscle tissue, I think, is almost universally beneficial, and we should spend a lot of time before we hit the age of 50 and try to accumulate as much as we can within our genetic limits. That's what I see. And that's just from my experience dealing with like really sick and injured people and watching them over time, what happens to them in the hospital and seeing them when they come back from the rehab centers and things like that. The people that go into a critical illness or injury in tip-top shape obviously do better. They do much better than sarcopenic, obese, couch potato. It's just the way it is.
So basically the question, we stopped recording, everyone, mind you. The question was for the sophisticated consumer, as you mentioned, with TRT. Right. People that have typically been on it 5-10 years and beyond, you actually recommend them to find out if there is a dose either higher or lower that is maximally beneficial for them. Maybe there's something better. The grass might be greener.
Well, that's right. The grass is always greener, right? So it's not so much that I recommend it. It's just that I'm not opposed to them experimenting a little bit. Again, once they're sort of, quote, dialed in, and that can mean different things to different guys. But again, I like to take a very long view on this whole TRT venture and just in health in general. If you're 40 and you're on TRT, you will probably be on TRT for the next 50 years, God willing that you live that long. So I have no problem at all, like you said, with the sophisticated consumer working with their doctor, whether it's me or somebody else, to try, let's try a higher dose. Let's see if I get some additional benefits at a higher dose. Let's try a different delivery method. Let's change up the frequency to see if there's any potential changes that we can, that we can have when we do that. So I personally don't have any problem with that as long as it's safe. I don't think patients should do that on their own necessarily. I mean, just it's always good to keep your doctor in the loop, right? If you want to change a medication, at least, do the courtesy of letting the prescribing provider in on what you're doing. And if they're a good provider and have your best interests at heart, they shouldn't have a problem with that, as long as you're doing something within the realm of safety. If you want to do something crazy, then, they should speak up about that. But yeah, to answer your question, I don't have no problem whatsoever with the example you gave, the guy who's been on 120 milligrams for 10 years, for example, and he's just curious to see, would I feel better at 180? Would I feel better splitting the dose up, doing microdosing? Whatever the case may be. I have no issue with that as long as it's safe. So have at it. That's how I feel.
No, it's a great answer. The reason it's a great answer is because, as you know, not all TRT practitioners see eye to eye, and the majority, at least, of the conventional guys, they will say without a doubt a dose of 200 milligrams plus is likely dangerous. But you're just not seeing that clinically, at least, are you?
No. Well, I mean, if you say it's dangerous, I would say prove it. And, there are plenty of guys, listen, it's always the dose that makes the poison, right? But it's also the individual. And in terms of their response, 200 milligrams may be way too much for one individual. They might get, you'll see like sleep disturbance, anxiety, you may see fluid retention, that sort of thing. You may have some like real issues at 200 milligrams. And for that person, maybe 100, 120 is a more appropriate dose. But you
see that?
The guys, it's common. I have. Yeah, I have. I don't have anybody currently in my panel who's taking that much. But yeah, over the years, I have seen guys who have shared, like, have been at other clinics that were started like right out of the gate on 200 milligrams, boom, and who had a really rough time with that. They just did not adapt well to that. It was just way too much, way too soon. Their body was just not prepared for that much androgen all at once. So yeah, I've seen guys have had those kind of issues with that. The flip side of that is there are guys out there and need higher doses. They have a certain amount of androgen resistance, whether it's an issue with the receptor, whether there's something else interfering with the ability of testosterone to do what it does. For whatever the reason, they require higher doses. I think Dave Lee's talked about this. I think he's talked about needing more than 200 milligrams in order to feel and function in an optimal way, to have complete symptom resolution, et cetera. So, that's why these cookie cutter approaches are not appropriate. There's a wide range of doses that are going to be appropriate. And that's where some of the experimentation comes in, like you mentioned. So my practice typically is to err on the side of lower doses, because we can always work our way up, especially if a guy is really metabolically unhealthy. They're often not prepared for a big dose of androgens. So, I've gotten more conservative over the years. And honestly, in all parts of my practice, I'm more conservative than I used to be. So yeah, you could always go work. We can titrate up and find that sweet spot eventually. But, that's where the dialing in process comes in. So, but I haven't seen like major, if you're talking about major cardiovascular issues at 200 milligrams, I just have not seen that at all. I've heard about guys, claim that their blood pressure became an issue with, at that dose, but that's just anecdotal stuff. I personally haven't seen it. So.
Neither. I used to be part of a forum where I would moderate thousands of bodybuilders. Not one person that I knew had an ER visit with moderate doses of testosterone up to 5. Not one person.
No. It's, testosterone it's a naturally occurring hormone. Your body is accustomed to it. It exists for a reason. It's in throughout the animal kingdom. This is a universally beneficial hormone when used appropriately. This is not some sort of a toxin that we're injecting. You can't say that about these synthetic androgens. Obviously, those are not bioidentical. And there are going to be issues with those drugs with high doses and for prolonged use. But testosterone is, that's the mother hormone, and your body's used to it. And people, I've been surprised, you probably have too, of how well men tolerate really high doses of testosterone. Like the bodybuilders, it's not uncommon to take a gram a week of testosterone, and many of them tolerate that just fine.
I used to be able to, definitely. Like, man, it was the best. It was so good.
Amazing, right? Yeah.
I tell you, I wasn't as lean as you, 5%, but let's say a good 11%. Like, there were abs visible. I ate whatever I wanted. I mean, anything. It was the best. I can't do it anymore. I don't know what it is. It's like, is it in my head? Yeah. That was going to lead me to this question. This question has been plaguing me because you're the person to answer it. So, have you ever heard of or seen the study, The Aging Penis?
Have you seen it? No, but I want to read it.
Brilliant. And yeah, I'm actually you could say I'm formally educated to be able to read statistics, right? It was a unit that I studied before I dropped out. So I think it was a pretty good study. And basically, over time, the penis loses sensitivity, especially in circumcised individuals, and it can even bend. And for some people, it bends all the way back.
It's called Peyronie's disease. Yeah.
That's the one. This study, by the way, in the Sex Journal, fascinating. But obviously, there's testosterone in there as well. And so the thought process is that testosterone, the exposure to testosterone over time, kind of like your pancreas, right? You become insulin resistant as a means of just aging. Like, just doesn't matter what you do, right? Is there a case to use more testosterone as a 40-year-old than you did at 30 for symptom relief?
That's a great question. I think that's going to be on an individual basis. So short answer would be yes, in select individuals. Again, if somebody comes, the physician, if somebody comes to you with a set of symptoms, if you go to a TRT clinic, you may have this scenario where, like, when all you have is a hammer, everything looks like a nail. So, not everything can be resolved with testosterone, and testosterone may mask, other issues that maybe need to be addressed in other areas. So, ED, for example, like ED is mainly a vascular issue. So you want to address endothelial health and lipids and all that sort of stuff. But testosterone, obviously, androgens can help with erectile function. But yeah, it is entirely possible that you develop the need for higher androgen levels in certain cases as you get older. I mean, you brought up the example of insulin resistance. Like, that's a perfect example. If you're a type 2 diabetic, as you get older, your insulin sensitivity naturally worsens unless you do something radical to correct it. You will need higher doses of insulin to reach, euglycemia than you would have when you were 35. As opposed, like, if you're 65 versus 35. That's just the nature of the human body. Insulin resistance, even if you're not diabetic, does get worse. So if you need a drug to overcome that, it sort of makes sense that you would potentially need to increase the dose as you get older. I don't see why that also couldn't apply to androgens potentially. So that's why I really think, that it's good to check levels, obviously, but there comes a point, and I say this to my guys too, these, the OG testosterone guys who've been on TRT for 10 or 15 years. I still check levels, but honestly, I don't really care what your levels are at that stage. I don't really care that much. I think we're gonna be making dosage changes based on clinical parameters like symptoms a lot more than levels. And I know a lot of physicians might disagree with that, and there may be plenty of endocrinologists that think that that's not appropriate. But to me, that makes sense at that point. Or whether your level's 1,000 or 1,500, for example, what I care about is, how do you feel? How's your overall health, including your mental health? So at that point, like, we're going to be changing dosages, and I'm not going to be, so wrapped around the axle about your numbers. Once you have been on TRT for a long period of time, I don't find it to be helpful. I make my decisions at that point based off of clinical parameters, not based off of numbers. So, if you're in your 60s and You're having breakthrough symptoms now that you didn't have in your 50s at the same dose of testosterone. Assuming everything else is okay and I don't find an alternative explanation, I have no issue at all with going up on the dose, and then let's see what happens.
Yeah, it's a great answer. I'll just rewind a second. You spoke about symptoms being way more important than the numbers. I have to confess, I have not had a blood test. It's coming up a year now. And I'll be honest with you. I ask my friends, they go, what should I check? I go, if you get this blood test and you see something on the lab work, will you change anything with your life? And they go, no,
Exactly.
Don't get a blood test then.
Don't get a blood test. Yeah. It's the whole idea. I talk about this a lot. Is it a decision node? Meaning, like, is the outcome of this test going to change management in a patient? And, you know, the residents that I work with, like, it drives them crazy because I'm always asking them, they want to order a test. Well, I want to get a CBC. Okay. Is that a decision node? Is the outcome of that test going to make any difference of whether this patient, how you treat this patient, whether they get admitted, whether they go home? You know, they kind of like squirm a little bit. They're like, well, no. Okay, well, then don't get it. Now, we usually still get it because other physicians want it. But the point is that you're right. At some point, you know, you don't want to just shotgun. It's kind of it's a side of like an inexperienced or like a newer doctor that shotguns labs all the time and, you know, follows those numbers a little bit more closely. And, you know, I think when you've been doing this for a long period of time, you realize that these numbers are just not that important, you know, within limits, you know? So yeah, if it's not going to change your management, don't check it. That's why I don't check estradiol levels. I do not check serum estradiol levels. They're useless. They're absolutely useless for a number of different reasons that we could, you know, talk about later, but they're not a decision node for me at all. And so, like, why would I have a patient spend money on a test that I'm not going to take any action on one way or the other? I'm not going to do it.
Yeah, let's elaborate on that quickly because I know people will say, tell us. So Broderick describes about estrogen within the cells and especially with using compounds like Masteron and Primabol and how the blood test can be an inaccurate picture of estradiol. So yeah. I'm assuming it's something similar here?
Yeah, exactly. So, you know, Broderick knows more about anabolics than I will ever. He knows more, his little finger knows more about anabolics than my entire body will ever know. So I'm not going to speak about the anabolic, you know, component of that. But what I will tell you is that estradiol in a man is an intracrine and paracrine hormone, meaning it is made inside the cells. So testosterone goes inside the cell. The aromatase resides within the cell. So the estradiol is made inside the cell and it is used inside the cell. And then some of it does leak out into and is used by the adjacent cells just within its little neighborhood. And then whatever is not used by those cells does leak out into the serum. And then when you go and get a blood test, that's what you get. But the levels within the cell are what matters with estradiol. And they vary widely from tissue to tissue. So they've done studies of this where they've done it with animals, you know, they've measured the blood estradiol level, and then they've looked at like the liver, the kidney, the brain, the prostate, all that sort of stuff. And some tissues, the levels correlate somewhat with serum, but in other tissues, it's totally off. It doesn't, not even close to being within the ballpark of that. So it doesn't tell you anything about what's going on within the cell itself. So if you take, let's say my serum levels are 50 for estradiol. I take an AI because I don't like it to be in bold and have an H next to it on the piece of paper. I take it down to 25 in the serum. I have no idea what I have done to my intracellular estradiol levels going on a tissue by tissue basis. It could have also gone down to 25. It could have gone to 0 for all I know, depending on the tissue. So that's you're just flying blind when you do that. And again, there are tissues, especially like your vascular system, where you do not want to drop your estradiol. You want to have nice, healthy estradiol levels. If you want to live a long time and keep your pipes clean, you need to make sure that the intracellular levels of estradiol in those cells making up your vascular system are nice and healthy. And if you take an AI, you have no idea what you've done to those levels. You have no idea. You can make a poor guess based off of what's on in the serum, but you have no idea what you've done inside the cells. And this is very mainstream. Like there's an article that I love. I think it's called Estradiol as a Male Hormone, written by two MD, PhD endocrinologists who've studied this. They're very mainstream. They're not TRT providers, but they have a big paragraph right at the end where they just basically tell doctors, stop checking serum estradiol levels. They're not helpful in any kind of clinical scenario. Just don't do it. And that's so that I follow that practice. Now, if a patient, if they request it, they just really want to know, of course, yeah, I'll order it for you. But just, I tell them, keep in mind, we're not going to do anything about this number. What I've seen it do more than anything is just cause anxiety and then lead into me having to give a 30-minute explanation about why we should not be anxious about this number. So it just, guys get very anxious about numbers on a piece of paper when really we should be focusing more on clinical signs and symptoms. So, but it's hard. I get it. You know, I'm a numbers guy. I do like numbers, but I've had to train myself in the world of estradiol, at least in the, you know, when it comes to estradiol, to not be triggered or not be influenced by what that number is on the piece of paper.
Yeah, man. This is a great answer because the next question I have for you leads into this. Obviously, with especially blood tests, there's a lot of conundrums, especially in the last 5 to 10 years. People are really speaking up about it. Lab tests not correlating to actual outcomes, right? There's another one, and I know you've seen this. It's getting talked about a lot on the TRT channels. If you have a moment, it'll be, again, it affects me. It affects many people from Northern Europe. Ferritin. The ferritin thing is coming up a lot.
It comes up. Yeah. It's really important. You know, what you're getting at is hemochromatosis, right? This iron overload condition. It is very common, in Northern European populations, but you know, it's in all populations. So I think it's worthwhile to, certainly if you're Northern European, to be screened for it. You can argue that, again, if we're going to practice individualized medicine, that all men should be screened for it. But it is more common in folks that look like us. That's just the way it is. So
I have it.
Oh, do you?
By the way.
Okay.
Yeah, so my ferritin ranges anywhere from 450 to 550. It's been over 1,000 after a surgery, but not always. Last time it was 900, but it's my transferrin saturation, which is the big issue, right? That's over 60. So I've got it, and my auntie had it. It's just the reason I wanted to ask the question is I'm not going to treat it. I have my own opinions about it.
Well, there's this, I'm sure there's multiple different hemochromatosis genes. And obviously you can be heterozygous, have one copy, or you be homozygous. And, you know, there's the, it's the H63D variant. These guys will have high iron index or saturation levels, but they don't have high ferritin levels. And, you know, if you ask the hematologist about this, they pretty much say those guys do not need to, you know, to phlebotomize because it's the ferritin that's kind of the marker that they're following there. There may be other issues neurologically with these, especially if they're homozygous with the H63D, but phlebotomy is usually not in the cards for them. And then, I mean, I'm not an expert, I'm not a hepatologist, but generally, if your ferritin is under 1,000, they don't typically get too excited about phlebotomy, has been my experience. Now, there may be individual practices there that are different, and there may be certain genes where maybe that is indicated. I don't know. I'm not an expert in that particular part of hematology, but I would say as long as your LFTs are not elevated, your liver function tests, and that your ferritin is stable and not climbing, and as long as it's, you know, it stays under 1,000, then that's probably reasonable. Now, what you could do, you could go get a liver MRI and get an idea. You can quantify how much iron is in your liver, and then that would sort of give you some direction. If you've got iron overload, you know, on an MRI, then maybe you would reconsider phlebotomy. So you mentioned when you had surgery, your ferritin level shot through the roof. If you're ill, if you're chronically inflamed, like here, like I mentioned earlier, I see all these dialysis and end-stage kidney disease patients, and they all have high ferritins. It's not because they're iron overloaded; they're chronically inflamed. So we just need to kind of get that out of the way. But in your case, it is a genetic. There's debate. Like I've read the papers about like what is an optimal ferritin level for longevity. And there's a lot of the bottom line is nobody knows. I've heard people quote somewhere between 50 and 150, a couple papers say like 80, maybe that's optimal, but do they really know? They don't know. I mean, there's not enough data on it. So, for someone like yourself, I mean, I would support you, obviously, if you're not interested in phlebotomy, that's fine. But I think you should do some other form of monitoring just to make sure that you're not getting iron deposition. Because, as you alluded to, most people, I remember the very first case of hemochromatosis I diagnosed on my own was a guy who was way down the path, already was having joint problems, already a diabetic, already hypogonadal, and he had, major iron overload. So you don't want to get to that point where you're symptomatic. So if you could keep track of that in a non-invasive way, like MRI, et cetera, that might be a reasonable thing to do every few years, just because you've got the genes for it. We all have genes that are favorable and we all have genes that are unfavorable. Protein A is mine, hemochromatosis is yours, so we just have to be a little bit more vigilant about, how we proceed through life. So
it's a great answer. Yeah, I like the way you navigate patients. You let them make the decision at the end of the day.
Yeah, it's not my job to tell people what to do.
Yeah.
I think doctors used to be more authoritarian, or people expected that. But the way I look at it, I'm just here to give you the best advice that I can, and then it's your life, man. You make the decision. I'll go home and sleep okay either way, in terms of But I want, you can't make good decisions without good information, right? So that's my role, and that's what this podcast is all about. You want to put out good information so that guys can then go ahead and make their own healthcare decisions. I have people in the emergency room all the time not do what I tell them to do all the time. And sometimes it's dangerous, and I really try to talk them out of it. But at the end of the day, it's not jail. I don't make you stay. If you want to leave, I had a guy that I defibrillated. He collapsed with a heart attack. I shocked him. He got up, he woke up, and because I wouldn't let him smoke a cigarette, he pulled his IV out and walked out the door. That's his decision. I think it's a very poor decision, but that's a true story. Crazy, I'm telling you. So, you know what? And he's competent to make that decision. So I gave him the best advice I could. Sir, please don't leave or you'll die. And he's like, F you, I'm out of here. So,
Man, before we go, I want to be respectful of your time, but before we go, could we talk a little bit about philosophy / your personality type? You mentioned before, several times per day even, you have to give families the bad news, like, hey, your husband's dead. How do you do? Are you numb to this at this point?
I mean, I'm not numb to it, but when you do this so much, you compartmentalize. You're not still a human being, right? I still take it home with me, but I'm able to compartmentalize it a lot better just because I've been, what they call it, stress inoculation, right? Guys in the military talk about this who've been in combat or in repeatedly stressful environments. I run cardiac arrest codes all the time, sometimes a couple times a day. So, my pulse doesn't get elevated, during those sorts of scenarios. So, you do become a bit inoculated to it. However, it doesn't mean I don't think about it a lot, that I don't shed a tear every now and then, for that person, because I'm still a human being. But, the reality is I have to go in and do that sometimes while I have literally 30 other people in the waiting room that I have to go see. Sometimes they're there for really trivial stuff. So, I work somebody for an hour trying to get them back. I'm not successful. I have to go in and drop this terrible news to the family. And then I have to keep my composure. I can't lose it myself. I have to keep it together. But it's the younger guys and the kids, those ones, every single kid that I had to work on and pronounce that didn't make it. I remember everything about that kid for 25 years. I don't forget those. The adults, The elderly people, you know, over time they kind of blur, you know, because it's clearly like not as tragic. But you know, when like I had some kids in Iraq, gunshot wounds to the head, you know, really nasty, gruesome stuff, and like you never forget that shit, you know. So, but it's you compartmentalize it so that you can still function in your life, and I don't want to bring that home to my wife or to my kids, you know, and I don't. So I'm pretty good about that. I've never gone to therapy. I honestly don't feel like I need it, you know, but I process things in my own way. And maybe that's just part of like me as an INTJ introvert. I'm not the kind of person that like, I don't need to like talk and get my feelings out to feel better. I just internally process stuff and then I just kind of let it go. But it still happens, you know, it's still hard.
Man, this is a reel of its own, because what I'm talking to an emergency physician who's also served time in the military. So you don't get to talk to people like you every day with both of those accreditations. So if you have a moment, I ask, what compels you to speak publicly now about this stuff? I completely understand the trade as an emergency physician. It pays well, it's fulfilling, but now you're going public with this stuff. Is there something other than, you know, potentially other areas of business that you can get into? Well, what's the message?
Yeah, it's a good question. So I started up my little channel and started having conversations like this with, you know, folks like yourself, mainly to, you know, to level up the quality of the healthcare in the men's health space, because I'm a man. This directly impacts me. You know, quite frankly, like I care about the well-being of my fellow man. And I don't like to hear these stories of men getting what I know is poor care. And you know, you see that online, you hear the stories, and I'm not saying that I'm like the world's expert in anything, but I have been around the block and I knew a few things and I'm learning more every day. I try to surround myself with people who are smarter than I am in their particular fields, because I would really like to see, testosterone therapy, HRT in general for men, you know, leveled up essentially. If you ask most mainstream physicians kind of think TRT and all this stuff is kind of a joke, or they think it's sort of, it's just a bunch of like steroid users, or it's, you know, guys just want to have big muscles and stuff like that. So I want to change that perception. And the best way to do that is to make sure that the providers that are out there, whether they're PAs, NPs, physicians, are practicing like top level medicine. And again, you know, not saying that I am like the paragon of medicine, but there's a lot of room for improvement. Let's put it this way, based off of what I've seen out there. And so that's kind of what I want to do with my channel. I've got some other projects in the works with like courses and things like that, just to help not just patients, but help people who take care of men do a better job at it. So I just like to see men get better health care. We talk a lot, women get, I think, better care than men in our country, especially when it comes to hormones. And I know that might be controversial to some people, but, you know, men don't, part of it is our own fault. We don't take care of ourselves as well as we should. So that's the other part of this and that's why I share like personal stories about my heart disease and, you know, other issues that I have, to say, hey, listen, guys, we need to talk about this stuff. It's nothing to be ashamed of to have low testosterone. It's nothing to be ashamed of to have ED. Let's work on this and like, get you the care that you need, essentially. And so I'd like to see the level improve over time. So that's what this is all about. I don't know if that answers your question or not.
Man, it's a great answer, but you're too modest. You're too modest, if you ask me. You see death regularly. You've seen murder, even based on what I can, you know, take from what you're saying. This is not someone that you can find easily in the space. Would you ever branch out? Because you mentioned how you don't need therapy. And I'm just going to put out my own opinions out there. So in Australia, I want to say that I grew up in a good area, but I didn't hang out in a good area, let's say that. And now there's this complete 180, this woke 180 trend where old tough lads are going to therapy publicly, crying on camera, doing this screaming thing where they put these headphones on and it's feminine as, and I know that this is going to come back to bite them, because women see this stuff and this is not attractive.
It's not attractive. No, I'm just, maybe it's my personality. I'm not big on public displays of emotion of any kind. You know, I'm a bit of a Mr. Spock at work. And so, yeah, I find that distasteful personally.
Yeah, yeah, your answers are they're more eloquent than mine. Would you ever branch out for men? Because look, I look up to you. You're like a papuchka to me. You're like someone I look up to. Would you ever branch out into the man space? You know, you've got the Andrew Tates out there, and to be fair, that guy's very entertaining. I don't particularly agree with everything he says, but he's smooth. He's smooth. And there are definitely a lot of things he says that I agree with 100%. Would you ever branch out, because your credentials, if you will, they're hard to find. Would you ever branch out into this man space in general, not just TRT?
I don't know. I think I would have to do it from a medical angle, honestly, because I really do believe in like staying in your wheelhouse, staying in you know, in your area of expertise, and not, I don't consider myself, I'm not an expert in philosophy. Also staying within my lane, which is the medical side of things, because there's overlap, obviously. You know, again, some men we're sometimes our own worst enemies, right? We don't go to the doctor, we blow stuff up all the time. And, you know, that needs to be addressed. So, you know, maybe within that context, I would consider something like that. I hadn't really thought about it.
You're very close, by the way. You've touched on training, then there's combat, then there's obviously getting a job that's meaningful. You know, I think maybe you take for granted now after being a physician for so many years, but to most of us, when we hear MD, we're very drawn because we know how much this takes to get that degree. We understand the work involved, that this is someone that can save a life. Like, you're always going to get respect. You know, no one is disrespecting a physician. So you're very close to encompassing the whole man medicine, if you will.
Thanks. Well, thanks. Yeah, that is the brand.
Yeah, exactly right.
Yeah. Well, you know, emergency medicine is kind of funny. It's not like you see on television, I will tell you that. There are moments of excitement and panic and complete insanity. That's like 5% of what I do. Maybe depending on the hospital, 10%. The other 90% is very mundane. It's ankle sprains, it's lacerations, it's anxiety, it's stuff like that. But the thing that keeps you on your toes is you have to be ready at any moment. We have a special phone that's like a siren, and that thing can go off. And when that goes off, you know that something serious is coming in, and you can be, you know, taking care of an ingrown toenail, but when that phone goes off, you've got to jump up and go. But most of the time, my job is actually pretty boring. Like, I would never, no one would want to watch a reality show of what I do on an average daily basis. You know, there would only be like 30 minutes of that would be exciting.
But even 30 minutes of that every day, I mean, you've adapted to it. You know, I'm soft now. I know that I'm soft. A few months ago, I got into an altercation. There was a couple Arab lads out the front. They just wanted to cause a problem. And I noticed that my adrenaline dumped harder than it should have. My legs started shaking. My breathing was too heavy. I knew that I hadn't been exposed to confrontations in ages. And so do you feel like you do need this regular exposure to keep it there?
In emergency medicine, in order to, like, it's not the kind of specialty that you could leave for a year or two and then come back. You know, opening up somebody's heart, which thankfully happens very rarely, but you know, there is a mental aspect to that. It's just like in your situation, you know, like if you know, assuming if you were doing Muay Thai and Jiu-Jitsu on a daily basis, you probably would have had a more calm reaction. When somebody really critically ill comes in, that's why I'm able to stay calm most of the time, is because I train that every day. And, you know, it allows you to just, you know, keep your cool, essentially.
Yeah, the take-home message there, everyone. I know doctor doesn't like to give people philosophical or mental health advice, but there you have it. The stress did you say it was called stress inoculation?
I don't get the fight or flight reaction that I used to get, like when I was an intern or a trainee. I was terrified, you know, brand new doctor, terrified. But now I'm not. Now I'm not terrified. I'm just highly concerned. There's a difference. So.
No, it's very valuable information, because I don't know how aware you are of the woke community, but the idea is that the exposure to stress is causing them trauma that they need to deal with in this extended period of time, and it's really starting to like consume a lot of their life, one particular event. But I guess what you're saying is almost the antithesis to this, which I also agree with, is more repeated events of stressful situations to be able to normalize it, if you will, or compartmentalize it, as you said.
It makes it easier. Yeah, I think it makes it easier. Yeah. You know, in the military, they guys do that. You know, that's why they go to SEER training, which is like survival, escape, resistance, evasion. I think, you know, where they get like a simulated POW camp and they go through interrogations that are kind of rough. It's to sort of prepare them for, if God forbid that happened to them in real life, they would have some sort of a framework to fall back on. It wouldn't be the first time that they experienced that.
Yeah. Yeah, I use you as the example because a lot of people will say, but they haven't been what I went through. Arguably, your situation is about as extreme as it gets. You know, murder, death, cutting people open.
Sometimes.
I mean, it's hard to argue.
Sometimes. Yeah. Yeah. But then, you know, it's sometimes it's very mundane. You see everything.
Thanks for sharing that stuff, Wade.
Yeah.
You know,
My pleasure.
it's interesting. This is the first time you shared stories like that publicly, or what?
Yeah, probably. Yeah. I try to keep it. I mean, I could share specifics with you offline if you want to hear more.
Please.
Yeah, I don't talk about that kind of stuff very often.
Yeah, well, I think it was actually helpful for people. So even though it may have made you a little uncomfortable, I can always not post that segment, but I really enjoyed the end there.
No, it's fine. Yeah, it's fine. No, it's all good.
Thank you, man. I think
My pleasure. My pleasure.
another good one.
I think so.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.